Just by a show of hands, is anybody here interested in a specific new modality or no? Show of hands. All right. Any and all. Gotcha. So I'm going to be talking about just a very brief BPH guidelines and sort of the way that the guidelines are written and the way I think about how to interpret them in the work of men with BPH or with lower urinary tract symptoms. For disclosure, I'm a consultant with Boston Scientific and an investor in Virtuoso Robotics. So BPH is a very, very, very prevalent disease with an ever-growing population and less urologists out there to help these people. BPH is incredibly common and is going to become more and more common. And so this is something that every physician probably who treats people with prostates, and certainly us urologists, are going to have to be dealing more and more with. And so the patient that comes to you for urinary dysfunction or lower urinary tract symptoms, they think it's BPH. The person who referred them to you thinks it's BPH, but it potentially is not BPH. And so I think the way that I think about this is that BPH is just one of the many things that could be contributing to the patient's symptoms. And the guidelines are a rubric, and the way I think about the guidelines is it's a rubric in which to make sure that that patient does indeed have BPH and that you're treating them for the right thing and not missing the mark. And so that's why these guidelines are so helpful, and that's our job, is to make sure that they get the treatment that will actually help them. And so certainly as a US-based urologist, the AUA guidelines is certainly what we follow most of all. And there's requirements, and then there's considered diagnostics that they mention. I think in all the guidelines, you're going to see a very consistent theme. The medical history, and I include the survey within the medical history because to me it's one and the same. It's essentially their HPI. Physical exam, which does include a DRE and a focused neurological exam, making sure that there's not some other insidious process going on that's contributing to their urinary tract symptoms. A UA is required. You're screening for hematuria, presence or absence of infection. And then it's plus or minus PSA testing. So PSA in the appropriately selected patient. So if it's going to change, if the presence or absence of prostate cancer is going to change their management, then it's certainly indicated. And I think the biggest thing, at least in the first iteration in 2021, was the assessment of prostate size. So as you're going to hear today, prostate size is probably one of the more important determining factors of what procedures a patient is a candidate for. And so getting an accurate assessment of exactly what the volume is certainly an important aspect. Things that should be considered are, and I put in quotations, objective measures. Now, obviously, these are the most objective we can get at this point. Obviously, there's some other diagnostics coming down the pike that potentially are going to be more helpful, but this is kind of what is described currently in the guidelines. So prostate size assessment certainly can be cross-sectional imaging, can be an ultrasound, and cystoscopy is also considered a way to assess prostate size. Basically anything above the finger wave is certainly what they kind of want. Uroflow and post-void residuals should be considered, especially if treatment is planned or being considered. There are some people who do it routinely. The guidelines don't say you have to do it. Cystoscopy, not routinely recommended. It's certainly, if it's going to change your management, then it's definitely a good idea to do. Or if you're looking for other diagnoses, or if you're planning a treatment that specifically requires that the shape of the prostate is conducive for the success of that treatment. And then urodynamics when it's not clear what the diagnosis is, or if you want to get a good quantification of the exact degree of overactivity or obstruction in that patient. So thanks to Dr. Zorn, we have the Canadian guidelines here. Very similar. They do a little bit more of a nuanced approach when it comes to the symptom severity, so mild to moderate. And really the diagnosis of the initial workup is essentially the same, but when they start to get more symptomatic, then more investigation is certainly indicated, because that obviously is going to probably lead to treatment. And the EAU guidelines are a little bit more prescriptive, as most of their guidelines are, than the American guidelines. The only real difference, at least at the beginning, is they do recommend a PVR during that initial sort of workup. And I think that that's kind of really the only difference. Instead of being considered, it's recommended. They also do a little bit of a different take, and they actually have a different algorithm when it comes to patients who have predominantly nocturia symptoms. And so I'm sure many of you feel the same way, but I always tell my patients that nocturia is like the white whale of the urologic symptomatology. It's a hard thing to really pin down and to treat effectively with certainly a lot of the modalities that I have power over. And so usually this is sort of an indication that there's probably something else going on or contributing to their LUTS. It may be both, but it certainly requires further investigation. So that it's kind of reflected in the European guidelines. And so I want to make it very clear, this is not my slide, I stole this, but I love it so much that I include it. But it's essentially, once you've taken all of that information and you can sort of categorize a patient into their findings, at least. This is a very helpful tool, at least for me, and to go over with with the patients that, here's kind of where you stand, and you might be more in the red, and potentially surgery is not a great option for you, or we're not going to improve your quality of life with this specific modality, or vice versa, where like, hey, you're all green, you're very obstructed, let's de-obstruct you. And so from the guidelines themselves assessment, so the initial history and surveys, and sort of figure out, is this irritative, is this overactive, or is this more obstructive? And to sort of identify potentially non-BPH diagnoses that are the cause of their symptomatology. What's required is a medical history, utilization of a validated questionnaire for the AUA, it's IPSS, physical exam, and DRE in the UA, and PSA testing in the appropriately selected patient. And then prior to intervention, it's certainly a size assessment, PVR and Uroflow, partly to have something to compare to and to associate with treatment effectiveness. And then cystoscopy, depending on the treatment option itself, and then pressure flow studies, UDS, in complicated cases. And then for me, I kind of go by this summary of the guidelines. So this is kind of what I do in clinic. And when I talk with our residents, this is kind of my thought process. So I pretty much always do a PVR. I think it helps to identify patients that are more overactive or obstructive. I add some other questionnaires. I like the lower urinary tract, the LEARN questionnaire. I always bring up family status, whether they're interested in fathering more children, and ejaculatory importance in that first visit. Uroflow, I don't do as often. It's just more of a personal preference and a practicality perspective. And then I do a cystoscopy if they're considering prostatic urethral lift, and then if they have a history of prior intervention. Those are kind of my hard and fast rules. And that's it. So thank you.